Okay. Okay. Very good.
Shall we start, sir?
Yes, please.
Good evening to everyone. Today, my topic is diagnosis and management of sinusoidal obstruction syndrome and other causes of hepatic dysfunction. Objectives: we are going to see, review hepatic physiology, describe the pathophysiology of common hepatic complications during HCT, and we are going to discuss about the diagnosis management of common hepatic complications during HCT. So liver, the primary function of liver is metabolizes the drugs, removes the toxins, degradation of worn out erythrocytes, synthesize the albumin, manufacturing clothing factor proteins, storage of vitamin A, D, E, K, and detoxify ammonia into urea, and synthesis, store and metabolize fat and cholesterol, and produce and excrete the bile, and metabolize the fat, protein, and carbohydrates. These are the functions of the liver. So liver is content of hepatocytes. Hepatocytes are the C functional cells of the liver and perform the astonishing number of metabolic. And it will usually roughly 80% of the cells will be occupied the liver into different 3 lobes. So hepatocytes will be covered in as a 3 lobes. So main in SCT, like what are the complications we are going to see means, usually we'll see sinusoidal obstruction syndrome, that is also known as VOD, veno occlusion diseases. So generally, like a lot of cases we'll see in the post-transplant time, and graft-versus-host disease, liver GVHD we'll see, and transaminitis we'll see, iron overload, hepatitis, fungal and viral complications are there with the liver. So incidence and etiology, most common liver problems that arise after HCT. So liver problem usually it will be after HCT, and incidents are 5 to 70%, and is high dose of the usually cause of high dose of chemotherapy and radiation therapy, TBI, and also inflammatory cytokinesis. So these are the etiologies for the SOS. So pathophysiology, disease of the small blood vessels in the liver. So in the blood vessels, the liver's blood vessels will get damaged, characterized by the occlusion in the venous flow out tract of the liver, and endothelial injury will happen in the vessels and the soft tissues. Activation of coagulation cascades, and usually it will occur like VOD. So this will occur usually post-transplant day 7 to nearly day 20-21. The risk factors are type of transplants are there. So usually in the allogenic transplant, there will be high risk of getting the VODs, and type of donor. So match unrelated donor or mismatched donors. In these cases, like there will be high risk of getting VODs. And conditioning regimen, like we are using busulfan, cyclophosphamide, and TBI. These are the high risk for to get the SOS. And if somebody has a pre-existing hepatic dysfunction, so hepatomegaly or some issue with the hepatic issues are there, they are high prone to get the risk factors. And sepsis, and as I told again, the radiation. So these are the reasons to get the VODs. So usually clinical symptoms, usually like if nurses has the very good experience in BMT, usually they'll identify the thing. So usually it start with the weight gain. So after post-transplant, day 7 or day 8, so weight will start going upside, and hepatomegaly will, and right upper quadrant pain, sometimes patients will complain, and bilirubin start going up, and there will be platelet refractory. Whatever if you transfusion, the platelets will not stay, and platelet refractoriness will be there. And patient abdomen guts will start going up. So slowly the abdomen guts will go, due to ascites, abdomen guts will start going up. So differential diagnosis are like sometimes like symptoms like rapid weight gain, may be also congestive heart failure may be there, renal failure will be there, sepsis syndrome, capillary leak syndrome. Due to this also sometimes weight may go up. And hepatomegaly also can happen in the congestive heart failure, fungal, EBV, and some tumor involvement. And again jaundice, again biliary infections, GVHD, cyclosporine toxicity. So this also thing are some drugs and hemolysis. This also may, during this also the patient may have the jaundice. And lab evaluations evaluated like again parental nutrition, GVHD, due to infections also sometimes the bilirubin may go up. So diagnosis approach, how we do the diagnosis for this patients are based on mainly clinical presentation. As I told, weight gain, bilirubins are going up, ascites, abdomen guts are going on. So this during this monitoring, the physical presentation will find out, and lab investigation again we'll keep eye on the bilirubins. And diagnostic tests are like we'll do the ultrasound if needed, CT we can do, and liver Doppler studies we can do. So the golden standards usually they will tell like a biopsy, but in our patient's condition it's very difficult to do that biopsies. Defining criteria are the subtle criteria will tell at least 2 of the following within 30 days. So there will be hepatomegaly or right upper quadrant pain will be there, or jaundice, or unexpected weight gain, or ascites will be there. Any 2 of the symptoms are there within 30 days means, so it is treated like a VOD. Modified subtle thing, at least 2 of the following within 20 days they will tell. Hepatomegaly, right upper quadrant pain, unexpected weight gain, more than 2%, or ascites. And the next criteria is bilirubin more than or equal to 2 within 21 days, and HCTs. And here also painful hepatomegaly, ascites, and weight gain more than 5% is there. And grading is again, if you want to tell mild means like self-limited, resolves completely without any specific intervention. So generally, if you start fluid restriction, that I will think that will clear the mild one. Moderate sometimes requires diuretics, pain management, and resolves most patients. In severe cases, the supportive care is important and does not resolve within 100 days. And transplant may, in severe cases, sometimes we may lose the patient also. So now what we are following the EBMT criteria. So the EBMT criteria is the format EBMT criteria we are seeing the presence of more than 2 following parameters: unexplained refractory of the plate, and other unexplained weight gain will be there, hepatomegaly, ascites, and increased bilirubin. So out of these 5 things, if the patient have 2 of the parameters, so we are treating with the as a VOD. Again pediatric, again mild, moderate, severe is there. Later you can go this format. So if the liver size is less less than 2, persistent rated 3 days refractoriness is there, and pulmonary functions less than 2 liter, patient is on oxygen. So this all thing will come to mild. In moderate case, again bilirubin will go to more than 2, and persistent rated refractoriness for 3 to 7 days will be there. In severe case, it will be more than 7 days. So this is about the EBMT criteria for grading the VOD or SOS. So main nursing management during this, the nursing management, what are things there means? Usually it will affect to renal, pulmonary, cardiac, hematology, and neurology. So in the renal, obtain daily weight. So weight is very important daily. Abdomen guts we have to check, and strict intake output chart we have to monitor, and monitor fluid restriction closely. And whenever we are preparing some medications, so if antibiotics or any other medication we are diluting 50 ml, we have to reduce the volume of that medication dilutions, and avoid nephrotoxic medications, and monitor the CSA levels are very important. And for pulmonary head and elevations, we have to take care of oxygen levels. We have to check, increase the patient sitting position, and respiratory sounds we have to see. If needed, we may go for blood gas analysis also. And cardiac side again, so there will be orthostatic hypertension will be there, and so aspected for fabrics also we have to do when we use the sounds will be changed will be there, and sometimes there will be pericardial effusions will be there, and tamponades will be there, and if needed also they may start like inodots may start like dopamine like supporting for cardiac they may start. Hematologically, we will see the CBC, and coagulation studies may require assess for bleeding and administration of the blood product. So during administration of blood product also we have to keep an eye, because as platelet dysfunction is there, if you give whatever overload of things not going to work, and if you give more platelets, it's going to worsen the further body. And neurologically, we have to assess the mental status of the patient, and so sedation, when we are giving sedation something, we have to keep eye on consciousness of the patient, you have to observe. So in the treatment for this SOS is fluid restriction. So we have to very closely, we have to monitor the intake of the patient, same time output. Fluid restrictions are very important. And generally we use the diuretics. Lasix very frequently used after transfusions, everything will give the Lasix. Sometimes, if for some case, we may start on Lasix infusion also, diuretics. And sometimes some people, like some consultants, they'll use the Utiliv tablets. And as I told previously, blood product transfusions has to be limited. And if the abdomen was worsening, so paracentesis may be needed, but again, in our cases, it's very difficult to do the paracentesis. And TPS will be used to see plasma-generating activities with the use and investigation agent. And the drug only drug which is like generally they use defibrillate. But in developing countries like in India, here like we are not so familiar with the defibrillate. Mechanism action of the defibrillation. Defibrillation is an augment plasmin enzymatic activity to hydrolyze the fibrin float. So generally, like when we give the defibrillate, so that will convert into plasmogen. The plasmogen will convert into plasmin, and the clot it will resolve the clot. And same thing, it will repair the damage of the epithelial cells. But the adverse effect of these drugs is increased risk of bleeding will be there, and hypersensitivity reactions will be there. The summary of the VOD or SOS, veno-occlusive disease is a severe complication of the bone marrow transplantation, characterized by ascites, weight gain, painful hepatomegaly, and hyperbilirubinemia will be there. Current treatment includes defibrillates, but there is still high morbidity and mortality associated with VOD, and earlier diagnosis and treatment is very necessary. So again here, the nurses, our close observation on weight, abdomen, this will be a very proper documentation will help to early diagnose this problem. Also, this will affect the hepatorenal syndrome. It's called hepatorenal syndrome, the later stage. The development of renal failure in patients with advanced liver failure in the absence of any identifiable causes of renal pathology. So the physiologies like hypotension will be start, and renal vasoconstrictions will be there, urine sodium reductions will happen, edema, ascites will decrease GFR will be there, and decrease urine output will decrease, bilirubin going up, and decrease flow hepatic values will be there. Clinical manifestation, hyponatremia will be there. Again, as I told previously, decreased GFR, oliguria will be there. Azotemia, so like urea creatinine levels will go up. Hypokalemia will be there, and BNO creatinine ratio will go up, and it will affect the cardiac output. And managements are actually this is a very complicated to manage this such a patient. And urine output, we have to very closely monitor the urine output, and we have to closely monitor the biochemistry values and restrict fluid intake. And vasoconstrictive medications may use, and sometimes albumins may transfuse. So next is about the other condition of the liver issues like encephalopathy, hepatic encephalopathy. So for the hepatic encephalopathy, we have to see the background what is the issue. So that part we have to see. And usually the causes for hepatic encephalopathy will be GI bleed, excessive use of diuretics, sepsis, and sedatives will be there. And usually in these conditions, ammonia levels will be increasing. Symptoms are like decreased loss of consciousness. The patient will go to loss of consciousness. Tremors will be there. Patient body will be shivering, and muscle twitching will be there, and lack of coordination. And management, identify the cause. What are the causes? We have to treat for the cause. Stop for GI bleed. Supportive case we have to do. And generally we give the more lactose, antibiotic, and avoid sedatives because patient will go to unconscious level and conscious levels will not be good. So we have to go for we have to avoid the sedations. So next condition is we'll see like GVHD. So liver GVHD. So usually clinical manifestation like it will be right upper quadrant when patient will start completing, and patient hepatomegaly will be there. The spleen size will be increasing, and the liver function test will be increasing values, and sometimes ascites, encephalopathy in severe cases we see. So usually liver function test will see elevated alkaline phosphate, bilirubin level, AST, and the coagulation will see. So when they do liver biopsy, this is a small image I have updated. And in the usually liver GVHD, it will again grading will happen like bilirubin. Like bilirubin 2 to 3 is there, means it is stage 1. In stage 2, it will be more than 3 to 6 it will be there. Stage 3 it will be 6 to 15, and stage 4 will be more than 15. Is it I'm audible to everyone? Hello?
Yes, Sandeep, I can hear you well.
Yes,
Okay.
sir.
So this is the grading of liver GVHD, what I told, like how bilirubin is. And management is, so again, the immunosuppressions, we start increasing the immunosuppression, steroids we may add, and again, sometimes cyclosporin, tacrolimus we may add, sometimes like, and sometimes they will add on Udiliv also. So other one condition is like a transaminitis, so inflammation of the liver. So again, sometimes called as hypertransaeminia, refer to having high level of certain liver enzymes called as transaminase. Hepatocytes affect after HCT. Usually it will affect due to condition regimen, immunosuppressant, antimicrobial agents, parenteral nutrition, iron overload, and some infection sepsis. It will lead to transaminitis. Just this chart just I have put it for just to know about each liver enzyme, how it will work. So ALT is the best test to detecting the hepatitis. AST is find out the liver and heart and other muscles. ALP is enzyme like bile and bile ducts. That's what I will see. Later you can go through this chart. So yeah, it will explain about each thing. LDH measures severe acute and chronic tissue damages. PT will explain about the liver produces the protein involvement of clotting factors. So like that, yeah, and albumin is more about the protein made by the liver. So this chart will explain about the each enzyme, how it will work. And these are the few medications what I have mentioned about the, just we have to know if somebody is going to hepatotoxicity, hepatic problems are happening for such patients. So before giving this medication, just we have to check with the doctors. Sometimes dose may reduce, sometimes we may hold the medications. So next condition is we are going to see the iron overload. So usually iron overload is a transfusion acquired. So as we are treating a lot of thalassemia patients, from the birth the patients will be on transfusions, and some due to irregular transfusion. Usually generally the iron levels will be high. Common toxicity can be overlooked. Pre-SCT diagnosis. So usually in pre-SCT we will see that due to malignancy and transfusion dependent like thalassemia, sickle cell, severe aplastic anemia, so MDS. So these are the conditions we will see. And facts are 1 unit of RBC contains approximately 200 mg of hemoions. iron deposits from the organ. Usually iron will overload in the heart and liver. So generally before taking the patients, we'll check the elderly patients, we'll check the TT-MRI, will say, can cause the life-threatening damage, body done is not. So generally in our body, iron will not exceed. So whenever requirement is, it will absorb from the gut, but it will not exit from the body. See in early and late SCTs. So we'll see many times the pre-transplant status and later stage also we'll see. Maybe associated with other toxicities like acute and chronic GVHD, infection, SOS, cardiac late effect, and transaminitis. So clinical symptoms are, again, it will affect the heart, skeletal system, hepatic, pituitary, CNS, pancreas, and hair and skin. So these are the things. So usually in pancreas, if affected, patient sugars level will go up. So laboratory thing, usually in our cases in India, developing country like India, we'll check the ferritin levels. So before taking the patient to transplant, we check the ferritin level, and after the transplant, when patients come for yearly follow, again we'll start checking the ferritins. In late effect, if the patients have high ferritins, sometimes we'll go for phlebotomy. And again, T2-MRI also will see the iron overload in the liver and the heart. So generally, post-transplant, if needed, we'll go for phlebotomy. Or in pre-transplant cases, usually chelation therapies will use. And this chart, just I have put the liver infection when it will come acute stage. So usually GVHD, acute GVHD will happen on particular these days, and chronic GVHD will happen more than 100 days. And what are bacterial infections will come during the acute phases, and what are viral infections will come. So this chart I have put it on the days wise. So other infections we'll see in the liver. So this now about we saw GVHD, we saw iron overload, we saw transaminitis, we saw, and we saw the SOS. So now is some of the viral which will affect to the livers. So generally hepatitis A, B, C, adeno and CMS will affect liver. The clinical manifestations will be there: fever, hepatomegaly, and jaundice. Diagnosis like PCR test will do if needed. Biopsy, that's a very rare condition. And management is supportive care and antiviral therapies will use. Fungal usually like Candida asperges, like this Candida infections will be there. And in fungal thing, the patient will have a persistent fever, high fever will be there, and increased alkaline phosphatase will happen, and again here also hepatomegaly will be there. So generally MRI of liver and CT guided biopsy will be done. Again management is again here antifungal therapies and supportive therapies. The next is about the bacterial. So E. coli and Enterococcus will affect the liver. Again here fever will be there, abdominal pain, and there won't be much hepatomegaly compared to fungal and viral. Blood cultures will sit for diagnosis. We'll do the blood cultures, CT scan, and ultrasound. And then for this also antibiotic and supportive therapies are important. So generally, like hepatic complications, conclusion is common hepatic complications. What we see in our transplant is SOS or VOD. So obstruction syndromes will see, GVHDs will see, and liver infections will see, and drug toxicities will see in our SCT cases. And risk factors for this all the liver toxicity and these all problems are like condition regimen. As I told, we are using the busulfan, cyclophosphamide, and body irradiations will affect. And allogenic transplant, in the allogenic transplant, we'll see more about the BODs and the GVHD sorting. And prolonged immunosuppressions. If patients is on prolonged immunosuppressions, such patients will see some liver issues. Sir, I'm done with it.
Thank you, Sandeep. That was very nice.
Thank you, sir.
So, Sandeep, let me ask you, how many patients have you seen with VOD? What is just, by memory, your estimate of the percentage of patients that had VOD, and how many do you think died of VOD in your experience?
So VOD expert, I have not seen much patients, very rare patients, because they have been improved with the diuretics. Very severe means there will be 1 or 2 patients, very few patients.
Right, exactly. So, yeah, the point is this, is that people describe, as you have described, which is correct, that VOD can be very severe, but for some reason, the patients that we have seen, and we're talking about, yeah, we have in our experience in the sort of SUNCALP network, I think the incidence of VOD will be in the range of 10–15%.
Yes.
So 1 every 10 patients will get it, but almost all will resolve. And we never use the fibrotide, which is, by the way, very expensive. So, and also my personal sort of belief is that it is so hard to demonstrate the real effectiveness of a drug in a disease which most of the time is self-resolving. So how do you show that it's really effective? So that's why we never use the fibrotide, because I don't think that it really does make a difference. Unfortunately, for many expensive drugs, drug companies have pushed for studies. There are some studies that show that the fibrotide maybe can decrease the risk of VOD if given before in high-risk patients, so it can prevent VOD. And also there are centers that will use it in thalassemics because they have liver iron overload, but in our experience, really, I don't think it would make a lot of sense to use the fibrotide prophylactically or in treatment. And because really VOD, as far as we can tell, it resolves almost always. If you give good supportive care, you don't give too much hydration, you give platelets judiciously, etc. The other point I wanted to make is that also, again, I personally don't like to use there's ursodeoxycholic acid because it has never really been shown to be that effective, but at least in the liver transplant setting has been shown to make cyclosporin less absorption less predictable, and that may be more of a problem than the little advantage that ursodeoxycholic acid can give. That's why also I don't think that maybe in some patients we have used it, but I'm not sure if we're using ursodeoxycholic acid in every patient, either to prevent VOD or to treat it. So I personally don't like it very much. I don't like to use drugs that I'm not sure that they are helpful, and also the ursodeoxycholic acid may have this issue of making cyclosporin absorption more difficult to predict. Is there anybody has any comments, questions before we move on to the quiz?
Sir, you told about Udiliv tablet, that thing. So, especially in India, like many of the consultants, I would say they like to use that thing, because I know, like you told, explained very well. So here, like,
I'm sorry, I didn't understand something. Can you repeat?
The tablet Udiliv.
Yes.
So in Indian setup, many of the consultants I have seen, like, they like to use that medication.
Yes, I know. Yes, it's very much used, but again, I think that we use a lot of drugs that we don't really know why we're using them. I think ursodeoxycholic acid, as far as I'm concerned, is one of them.
Yes, sir.
But okay. So anybody else wants to make any comment, questions? Okay, so let's move on to the poll then. So you have three, let me see what, you have 3 minutes